Good evening. Yes, we are back. Thank you for patiently waiting, and we apologize for the break due to technical delay. Now, Dr. VP Paili, MD, FRCOG, Senior Consultant, Head of the Department, Rajgiri Hospital, Aluva. He'll talk on the Kerala experience on MMR reduction. Dr. Paili is the State Coordinator for Confidential Review of Maternal Deaths, Kerala, and he is the past President of KFOG Kerala, formerly Professor and HOD of Government Medical College, Thrissur. Over to Dr. Paili. Sir, welcome, sir, to this session.
Hello. Hello, I hope I am audible.
Yes, sir, you are audible.
Thank you very much. I should particularly thank the Department of Health, Government of Kerala, especially Madam Shailaja Teacher, the Chief Minister, the Health Secretary, Dr. Rajan. And I should actually mention, when we describe the journey of Kerala Federation as a partner to the Government of Kerala, we had been helped by the previous health secretaries as well as NHM directors. I should particularly mention Sri Bharat Bhushan, who actually started the Kerala Federation's first initiative to do confidential review of maternal death. Sri Rajiv Sadanandan, who probably had the longest stint in the ministry and who had been instrumental for many of our activities, and the present Secretary, Sri Rajan, Dr. Rajan Kobregade. And of course, we had the NHM directors like Dr. Beena, Sri Keshav, and present Dr. Kelkar. Coming to my point, what I propose to do is to share our experience in MMR reduction in Kerala. And I am talking about this in the capacity of the State Coordinator of Confidential Review of Maternal Death, one of the partnering projects of the Government of Kerala with the Kerala Federation of Obstetrics and Gynecology. Go back. Every society, every government strives to achieve the lowest maternal mortality ratio because it is considered the best indicator of health of a community. So the Government of Kerala declared in 2018 its target to achieve MMR of 30 by 2020 and 20 by the year 2030. Because MMR reflects the position or the status of women and girls they enjoy in the society, and a low MMR was one of the targets of the Millennium Development Goals of the United Nations, which ended in 2015. But following that, when the world body wanted to continue to work and declare the Sustainable Development Goals, which are to be achieved till by 2030, maternal mortality reduction was one of the targets. Certainly, you all know that. The target for the whole of India is 70 to be achieved by 2030. And you heard just earlier, Dr. Rutter saying that we may or maybe a little lagging behind. But Kerala had achieved that long ago. And so that is why we decided that we will have a new attempt to target. And I am glad to report to you that we have already achieved what our Chief Minister and Health Minister declared to achieve by 2020. That is an MMR of 30. With the available data, we can say that it's about 29. Of course, if you avoid the accidents. And even this year, till January, from April to January, we have stayed in the same range of 30.74. So what I'm trying to tell you is that what we have achieved is something which we hope we'll be able to sustain. I thought we will take you through the journey that KFOG was a party to the Government of Kerala to achieve this. Kerala has many favorable factors to achieve a low MMR. Our female literacy is so good. Institutional delivery for a few years had been almost 100%. We have large number of health centers, especially comparing with some of the other states in the country. Our transport system is certainly much better than what's available elsewhere. And more than anything, our people are willing to spend for health and education. But there are some downsides as well. Some parts of the state have settlements in very inaccessible areas, and they have transportation problems as well. We have a large segment of tribal population in the hilly areas of our country, our state, and about 70% of health delivery, including the delivery, is in the private sector. So that is not in the direct control of the government. If you analyze the situation in Kerala, we have about 4.5 to 5 lakh deliveries per annum, out of which government sector has only about 30% and the private sector has about 70%. And if you look at the data in this slide, which was provided by Dr. Beena a while ago, in 2007 to 9 period, as per the sample registration system, Kerala had an MMR of about 81. So we were way ahead of the rest of the country. But still, MMR compared with other indices was high, and so we thought we have to work to improve on that. This is another of the downside which I mentioned earlier. If you look at the terrain of Kerala, you can see that we have that hilly terrain which is very much inaccessible for many. And if you look at the distribution of MMR in the districts, there is such a wide variation. In some districts, it's up to 19, whereas in some others, it goes up to 47. So such heterogeneity is there in our data. So we thought we had to evolve a unique strategy to bring down MMR in our state. We looked at other countries. Everybody quotes Sri Lanka and Malaysia, but the example of those countries are not typical for other developing countries or states, especially for India. Because in those countries, most of the healthcare, almost all of the healthcare is funded by the government. Whereas, as we said just now, in India, it is about, in Kerala also, about 70% under the private. And as you know, insurance doesn't cover maternity care by most of the providers of insurance. And the government spending on health, government of India, as well as government of Kerala, is not as much as we would like. So maternity care under the private sector leads to out-of-pocket expenditure, and for the poor among the community, it's a big burden, especially because insurance doesn't cover. So that is why this is a reality across many states and many developing countries. What we have achieved has more relevance to the rest of the world and our countries because there may be some lessons they can take. What we did was develop a partnership between the government, the private healthcare, and professional organizations like KFOG or our pediatric colleagues organizations and the IMA. This is the main aspect that we want to highlight. KFOG was established, Kerala Federation of Obstetrics and Gynecology was established in 2002. And one of the declared objectives right at the beginning when we started was to work towards reducing maternal mortality ratio. This was helped almost coinciding with the origin of our federation by a workshop organized by ZRO, that is Southeast Asia Organization of WHO based in Delhi. They had a workshop in 2003, which I was fortunate to attend. And there, Kerala Federation proposed to that workshop that we would like to start confidential review of maternal deaths, which is the best way to audit maternal death in the world. And this was practiced by the UK for about 50 years before that. And the WHO accepted. And when I came back, I presented it to Sri Bharat Bhushan, the then Health Secretary, and the government at that time also accepted our proposal. And WHO supported a workshop that we did in Trivandrum. And this is part of some of the participants of that. We can see world-renowned people like Dr. Philpott. We can see WHO representatives. We can see representatives from the UK. And on the right side, the then health officials with Sri Bharat Bhushan in the center. The government of Kerala was kind enough to issue an order asking all hospitals, all delivery points, government as well as private, to hand over the maternity records of the maternal deaths to Kerala Federation for analysis and auditing. That was a big step. We did the audit following the principles of no name, no blame. No punishment was awarded, even if probably negligence is not a right word, but a fault was found in the management, no blame. And this was followed for more than 50 years by the British and found to be the best way to analyze maternal death and learn lessons from that. And we had, fortunately, the senior and middle level obstetricians and many senior non-obstetrician colleagues joining us to assess these records and arrive at the cause of death and what we can do to prevent it. The aim was to find out the real reason for the death, medical as well as the circumstantial reasons for the death, without assigning any blame on anybody. And this is one of the small groups that joined together to analyze. One of the early photos I can provide you. And we published our findings. This was the first 2 years, 2004 to 5, Why Mothers Die, Kerala, published by our federation. And the second volume came covering 4 years up to 2009. And the next one also in preparation. And we had, fortunately, the deaths were manageable, only under 200 at that time. And confidential review committee could get a substantial number of those for analysis. And we analyzed and found out why mothers were dying. And we found that hemorrhage and hypertension were the leading causes of maternal death, followed by other conditions like heart disease, sepsis, amyloid embolism, thromboembolism, placenta previa, and unfortunately, suicide. Based on this knowledge, we decided what we can do to prevent these deaths. And this was following the principles that was promoted by WHO. WHO changed the emphasis from audit to what they call MD-NMSR, maternal death surveillance, that is audit and then response. Respond to the findings. And that's exactly what we did when we analyzed and found what the causes were. We decided to train all types of staff, obstetricians, nurses, nursing assistants, from the central and peripheral hospitals. Unfortunately, at that time, UNICEF helped in the training by funding some of the training sessions under the banner of Women and Child Friendly Hospital Initiative, which was at that time. And the government of Kerala kindly agreed to extend the training up to the community health centers. Because at that time, we had nearly 600 plus delivery points in the state, including private and the government. And the Kerala Federation provided the faculty to train in all the centers. And the KFOG continued to the surveillance and response to that by identifying the leading causes of maternal death like hemorrhage and hypertension, and wanted to find out what can be done for that. Another factor that came out was the doctors as well as the nurses were not equipped to tackle obstetric emergencies. Whereas in the Western countries, they all have to be following the certified courses like ALSO or MOE, that is Managing Obstetric Emergencies and Trauma. To practice obstetrics, any doctor has to follow these courses, pass these courses. But in Kerala, there was nothing like that. So we started what we call emergency obstetric care and life support training programs, and went with that training across the state to all districts, conducted even 2 per district. And that was spread out not only to the government staff, but to the private as well. Because there's no point limiting your training to the government staff where only 30% of deliveries take place, whereas 70% was under the private. And the government was kind enough to accept the principle and agree to extend the service and training to all doctors and nurses without barrier of private or government. And we conducted separate modules for the doctors as well as the nurses. By 2012, the then Health Secretary, Sri Sadanandan, Raju Sadanandan, brought in NICE International to Kerala and wanted them to work to find out what we can do further to improve on the maternal mortality scenario. And they looked at the books that we published, our findings, and helped with us to what is called the project of quality standards in obstetric care. I remember our Honorable Health Minister, one of her first meetings she addressed when she joined was one of the meetings at Thaikad on this, one of the training programs, quality standards. Faculty from NICE International and Kerala Federation sat together, worked out what we can do to address these problems. Simple measures in meetings like these, where there were faculty from abroad sitting with us, and then we worked out what can be done. Simple programs, simple steps, and we worked out that simple 5 steps to address the problem of hemorrhage, another 5 to address the problem of hypertension could be spread across the state. And an MOU was signed, and the British minister visiting the Kerala at that time signed the MOU with the then Chief Minister and the Health Minister and the Health Secretary. And we went on to have periodic training meetings and spread the message of quality standards across the state. It was piloted in 8 hospitals, but later it was spread across to the whole state. CAREFORD then also provided the technical support for training all categories of staff in improving. But in 16 to 18 period, in fact, from 14 onwards, Government of India, following the directions from WHO, said that you should start doing near-miss audit. And we, under the guidance from our health secretary at that time, agreed to do that and started the pilot in the government medical colleges, 5 medical colleges. And we really were surprised to see that near-miss causes were almost similar to the real miss or the death causes. And as agreed across the world, we also feel that audit of near misses will be the better way of auditing to identify the causes of maternal death and preventing them. And that is our future thrust. Then 2018, our Honorable Chief Minister, as well as Honorable Health Minister, declared what I said earlier, that we should aim to have a maternal mortality ratio of 30 by 2020 and 20 by 2030. At that time, this SRS, sample registration system, had predicted that our maternal death ratio was about 41, which is now again put as nearly 43. And bringing down even 1 point when you come lower and lower is so much difficult. So we had to hasten our activities to achieve the target. So to address the main problem of hemorrhage, we ourselves worked out and developed instruments like clamps to address the hemorrhage, clamps like this and like this, to address the problem of placenta accreta spectrum, which was notorious to lead on to maternal death even on the table in the best centers of the country and across the world. We developed ourselves very cost-effective methods to tackle these problems, or even suction cannula developed by one of our colleagues, Samartha Ram, to address the issue of PPH. So innovations like this were put into practice, and we had to improvise like this to achieve our aim of bringing down. One other development at that time was we thought about how further can we work, and that is how we ended up promoting 2 aspects, and that is MD-NMSR, difficult tongue twister, but I will explain what it is, and the ORRP. MD-NMSR stands for maternal death and near miss, surveillance and response. Earlier, we were auditing maternal death centrally. We thought that we have to decentralize it, take it to the district level, involve obstetricians in the district so that they will feel more committed, more involved, and immediate returns will occur, because our maternal centralized audit was giving the results a few years later. And these meetings, which were to be held at the district, will give the results immediately. And so we started MD-NMSR at each district. The district collector was to be the chair. In his absence, the DMO or even a senior member. What is important was at the district level, all the obstetricians were coming together to audit the near misses. And if there is a death, that also will be presented there, but not discussed in detail, because that will be difficult to keep the anonymity. Unfortunately, when we started this, after about a year of its going, COVID struck and we had to temporarily stop it. But then later, we all have started it as online programs, most of the districts in the district level. So this happened in end of 18, 19, and of course in 20, we had the COVID striking. But still, the idea was spread, and many of the obstetricians in the periphery feel so glad that they started it. Another step that we took was ORRT, Obstetric Rapid Response Team. This is out of the realization that when an emergency occurs, immediate help is what counts. Help coming in terms of ICU care or anything later on will be of no use. So every delivery point should have a team trained to give emergency care when a serious complication occurs. At least one member of the team should be present in the hospital round the clock. Wherever there is a delivery, there should be somebody trained, maybe a nurse, maybe a doctor available round the clock. Specially trained doctors were present in the team and they are competent for venipuncture to start the lift or give emergency resuscitation, or if it's a bleeding, steps to stop the bleeding, like what we discussed earlier, use those clamps to stop the bleeding. So that was the principle of ORRT, which again, we have taken workshops across the state and it's an ongoing process. CAFO conducted training sessions at the district level to develop ORRT teams, and there was passionate uptake of this program by all the hospitals, private and the government. So we realized that we could identify the causes of death. Number of hemorrhages, number of hypertension deaths have come down, and because the total deaths have come down, percentage may remain the same, but the numbers have come down. Sepsis, heart disease, amyloid embolism, the causes remain more or less the same, but the numbers have come down, and that is how we could achieve what we told you a little while ago. This doesn't mean that we haven't got problems. We have achieved what I told you, the MMR of what we looked for, but there are problems. Suicide is emerging as a major threat, and maternal suicide is still a major problem for us to tackle. Even though we have transportation much better than elsewhere in the country, ambulance service still, I cannot say, has reached the perfect level that we want. Insurance for maternity care, many of the insurance companies are still reluctant to take it up. The coverage is very sketchy. And in spite of all the developments that we have, data collection is not yet completely electronic, and there's a lot of improvement required. And there are many other issues which we in our meetings discuss and find out. But attempts to bring down MMR should be a dynamic, ongoing process, because the women giving birth change, the doctors and nurses change, and at the moment, as all of you know, nurses change a lot. There's a big drain of nurses at the moment in our state and in our country. Just like what happened regarding the doctors in the 60s and early 70s, now it's the time of drainage of nurses from our country. And there has to be a dynamic program of training and keeping the standard of care update. So the system should prevail. That is what I have to suggest. MMR reduction will be possible if there is cohesion and commitment on the part of different sections of caregivers, whether it is public or private. And what I have to convey is a professional organization like CAFO can be a catalyst to bring together the different sections that can play a role in bringing down maternal death. This is what I would suggest the Kerala model, the lessons from Kerala to other countries and other states. Thank you very much once again for the opportunity to present our experience.
Thank you, sir. Thank you for your detailed presentation on Kerala's efforts to reduce the maternal mortality rate. Now, there is a slight change in the schedule. We'll be rescheduling the 4 talks from the Kerala scenario to 8:15 p.m. Now, next session will be Dr. Sachidananda Kamath, consultant pediatrician, Indira Gandhi Cooperative Hospital, Ernakulam. He will be speaking on the Kerala's experience on infant mortality reduction. He is the national president of Indian Academy of Pediatrics in 2015 and taken a significant role in the baby-friendly hospital initiative, child-friendly schools initiative, and cessation of tobacco smoking in public places. Welcome, Dr. Sachidananda Kamath, to this session.
Am I audible?
Yes, sir. Yes, sir, you are audible.
Audible? Thank you. Thank you, madam, for giving me an opportunity. Thank you. Honorable Minister Shailaja, madam, and other dignitaries in the Zoom platform, plus the members who are watching this Zoom from various parts of the country, Kerala as well as outside Kerala and outside India also, those who are watching. A very good evening to you all. My topic today is IMR reduction experience from Kerala. We all know this IMR is regarded as the important and sensitive indicator of the health status of a community, and it reflects the living standard of people and the effectiveness of its interventions for improving maternal and child health. Trend in IMR in India in the last 1 decade, it has reduced 40% decline from the 55 to 30, 50 to 32. But we have huge variation within the country. Madhya Pradesh having major states like Madhya Pradesh, Uttar Pradesh, Odisha are all having more than 40, and we have the other areas that is less than 10 in Kerala as well as Goa and the other areas. This was the data from the SRS in 2020. Now, let me go through the story of how we achieved in the single digit IMR through our journey. In a few slides, briefly, I can inform you what was the role of each person in this. This is a slide which is which the IMR of Kerala as well as India in the last 4 decades. That means 4 decades. It has declined the India's IMR to 70% from 148 to 44. That means 70%. At the same time, Kerala could achieve that in just 20 years. But after that, in 1991 onwards, the decline is very stagnant and we could not achieve further decline. And what is the major issues, we don't know. And the Kerala had throughout the time, in 1 decade, it is 12, 14, 15 or just up and down. And this made us further reduction of IMR in Kerala. Is it a dream or a reality? Yes, rate had almost stagnant for many years, nearly a decade, which prompted us to look into the issues identified in the routine statistics, that is conflicting figures from different sources of data. SRS gives a different data, NFHS gives a different data, collection of data is different from states, and it is not an easy job to get it collected for a state where it has reached to the below 15. Causes of the preventable and the burden are not known. Regional variation from one district to the other, and the deaths occur in the transit or the outside institution in the periphery were not been reported. This led to the questions which we have raised. That is, what are the factors responsible for the stagnant phase of IMR? Whether is it merely significant ups and downs of 14, 13 or something? And we have to look into what matters for that. And for the last 10 years, the same IMR. Can we further reduce the IMR? Is it a reality what we can do? If so, what are all specific strategies for such reduction? This prompted us in looking into in the various capacities and move forward with one proposal to the government of Kerala, NRHM at that time, and Indian Academy of Pediatrics join hands to study and identify the cause of actual deaths in Kerala in urban, semi-urban, and in the tribal areas, to look into in a particular 1 month to identify the exact infant mortality and the exact causes of infant death in these 4 districts, which had 1 month duration through sensitization training and a vigorous training to the junior public health nurses to report every death through them and analyze that. And surprisingly, in 2012 itself, we could get this Ernakulam as 4.5 as an urban area, and in the Wayanad and Kollam had 8.5 and 10.7. We looked into the causes of the death. 75% of the deaths were in the neonatal period, and above neonatal period, that is infant deaths, were 25%. And out of the neonatal deaths, the priority goes with the top 3, that is prematurity, congenital anomalies, and sepsis, which correlates with the developed countries in anywhere in the world. So in India, when we compare with the other states, the deaths in that infants are prematurity in the neonatal, and post-neonatal they have the pneumonia and again birth asphyxia, were the 3 causes of death for these infants. So we have calculated at the same time the SAT hospital, the major hospital in that time, and that also shown that the major causes were prematurity, congenital anomalies, and infection. Similarly, after the post-neonatal period, when we looked into what are the deaths due to for the pneumonia, the 70% of the total deaths were due to pneumonia post-neonatal, and of this 85% had comorbid, especially on the congenital heart disease. This has made us think of what is special for Kerala and what is the special strategies to work out, whether it is general or specific, and make a series of workshops and the brainstorming sessions to bring out the causes and their strategies, general as well as the specific strategies. And we have presented that to the then mission director, Dr. Veena, at that time, with this and with that preconceptional before pregnancy, which leads to the perinatal during pregnancy, prenatal, perinatal, neonatal, and post-neonatal points were looked into through the general as well as the specific strategies. Some of the initiatives or some of the recommendations which we have suggested has been taken by the government, and we should definitely say that the few of them which I have mentioned here, it is the metabolic screening, not only metabolic, now there is the 4 limbs have been screened for the SpO2. So screening program, OEE program has been mentioned in the screening program. Sepsis, we are through that AMR program. For the last 3-4 years, we have been regularly doing AMR program. NSSK, that is for the not only for the birth asphyxia prevention, it is for the essential newborn care. 2-day workshops conducted. I'm coming to that. Infant death audit, just like obstetrician, which they have come out. We have had that infant death audits in every district. Those who have died in less than 1 year, was 10% of it were looked into, and what the causes have been and the remedies ought to go about. Ridhyam project, very novel project by the government, and where we had at that time only one government institution for the heart surgeries, which they for the poor patients. So with the PPP, private public participation, the 4 other institutions, private institutions, were accredited to do the surgeries of these poor BPL children, BPL infants and neonates, where they were all transported from various places to these 4 institutions also. JSSK free of cost, AK program, then free transport, management of the disability, another project, and immunization campaigns, just like Immunize Kochi and other things. These are all the few of the things, specific strategies which we have mentioned, and my successive speakers, Dr. Madam, DHS Madam Dr. Sarita and Dr. Srihari will be explaining the impact on this project. Lack of time, I will just move on to that another project which has IAP was totally involved in this NSSK for training program for the basic newborn care and the resuscitation evaluation. It was started way back in 2009, was moving around, and we could train TOT, that is trainers were 420 trainers were trained by the national trainers from the national level project and national level speakers and the trainers who are Dr. Naveed Thakkar, Dr. C.P. Bansal and others, Dr. Vineet Saxena, because are all came here and took the TOT, and we could finish that, and the project were move on for as a two-phase by making it happen. That is 247 workshops were conducted, and we could train nearly 10,000 healthcare workers, whether it is government or public. We could finish it within that two phases. We could finish nearly 10,000 healthcare workers, which we never stopped at that stage. And again, SNCU project in which 171 healthcare workers were trained, and the SNCU with 71 doctors and nearly 7 workshops of 14 days were conducted. These are all the few photographs of the NSSK workshop, which were trained for 10,000 healthcare workers, whether it is private or public. Public was supported by the government, private partly was supported by IAP through the SCSR funding through the IAP. We never stopped at this stage. We went one step ahead. What is the impact? What has happened for this training? So we have conducted an external survey and external evaluation at the time of training program, after 6 months and after 2 years. And the results were very much encouraging, that 83% of the study participants revealed that they give the systematic newborn resuscitation confidently, and birth asphyxia management is not at all a big problem to them. And new skills gained, 90% of 99% remember that whole of the program, and the systematic newborn resuscitation were this for the more than 88%. This means that even after 2 years, they were sustaining those things, but there were shifting of the nurses with the other departments that had a problem. Infant death training program. The training program started with training to all the district office bearers as well as the trainers, which was done. And every month, 10% of the deaths were called to look into what is happening for them. And this were evaluated and looked into what to be done next. Review of the meeting of the revamping of BFHI as well as the training program on the lactation management training programs. So this also has promoted. We could train around 400 lactation management course healthcare workers for doing this lactation management, which will help them for the promotion of the breastfeeding. Then came the news in 2017. We could achieve this 6 in the urban, 5 in the total, which has come to 6 from NFHS 2005-6. After 10 years of NFHS survey, it has come to 6. The same time when we did the DHS survey, actual death, it was also 6 at that time. Reported by the press in various national and the international media, and the SDG target, which was fixed in 2015 to reduce the infant mortality rate by 2/3 in 2020 and 50% in 2030, we could achieve that before 2017. This was our target, which was meant for the 2020. which we could achieve it much earlier. Now, strategies which we were focused are focus on the newborn survival, which we have mentioned about that, scaling up of the evidence-based intervention, and address to the prematurity and congenital anomalies, which I have mentioned that, and the specific state health initiative, transportation and other things, which the government supported. And to that knowledge, 70-30 deliveries has come to a government level 60-40. So that means government setup also has become more and more approachable, and more deliveries have started happening. And we are not forgotten the Attapadi problems, which the tribal area, and we have looked into that, and the making the nutritional rehabilitation, screening the anemia, and the support group, native groups were also looked into in the tribal and the vulnerable population. We looked into the similar kind the remaining 3-4 years. This still has 6-5. So similar kind of things which is happening. If we look into that, when it was 70-30 was the neonatal death and infant death earlier, which has reduced to 63 as an average for Kerala. That means the neonatal problems are started having the fruits out of it, and the minimum, that is the Ernakulam had the 3.3 infant mortality rate, but we were worried about what is happening for this 2,434 infants. Four steps in the general categories, that is policy breakthrough for filling the critical gaps and skill. That means the strengthening of the primary care. Out of our studies, 9 deaths occurred in out of 75 at home. So that prompted us critical gaps, short-term and the long-term critical gaps, training programs, skill programs, PPP model, efficient things have been. 3 quality initiatives, that means professional initiative, administrative initiative, and the demand side initiative, which is interlinked. Initiative from the profession need with the adequate administrative endorsement and the support. Demand side, we have BCC activities, that is behavior change communication. Third, which is the major thing in the general strategy, attaining the achievable through willful and consecrated effort for added boost towards new governance initiative. Benchmark and the standards were developed with the local adaptation for internally accepted thing. And of course, the interdepartmental, that is housekeeping and the other medical equipments, everything was looked into that. Fourth one is major thing, which is maintaining the already achieved gains and ensuring the sustainability, which is very important. Adequate preparedness, impact evaluation and feedback, which we have started. Social auditing and the other auditing, boosting the motivation and incentives for the various capacities which they are, and use the appropriate technology interface with them. This was possible only with the team effort, and I can vouch on that. The team, which was professionally organization, which was helped, that is IAP, FOXY, TNAI, IMA, KGMA, others, with administrative department, DHS, DME, NHM, and health department, through the bureaucratic level push. That means health department, family welfare department, and NHM SMDs, with their political will from the respective health ministers, through the healthcare workers of ASHA workers, JPHN, doctors and others could achieve this. If I fail, I will be failed if I don't mention few of the names at least for the project which has been, they have been working. That is Dr. M.K. Sinha, Dr. Raj Mohan, Dr. Lelda Kailas, Dr. Junaid, Dr. Riaz, Dr. Matthew, Dr. Ramesh, and senior members and the president and the secretaries of the consecutive years of the IAP Kerala State, Dr. Divakaran from the NNF, and the OBG counterpart, our beloved teacher, Dr. VP Paili, sir, and Dr. Rakesh, who had analyzed the first data which we have analyzed in our study. Government of Kerala, we could not, we will fail if I don't mention Dr. Sri Rajiv Sadanandan, Health Secretary, was throughout our time, and now Dr. Rajan Korpagade, our Principal Secretary. NHM directors, right from the Dr. Dinesh Arora, Dr. Beena Sri Keshwendra, Dr. Ratan Kelkar, and the team of the members who are there in the NHM, Dr. Sri Hari, Dr. Beena, and the supporting staff, which has made our whole teamwork made it possible. And I will quote now, it always seems impossible until it is done. And it is done, the SDG goals. And if I don't, and we will not stop till the goal is reached, and every child should celebrate their first birthday in our state. 2,434 babies also should be salvaged to have their first birthday. Until then, we will not stop our goal, and we will still keep on going with this team work. And I especially thank the current organizers, especially our Principal Secretary, Dr. Rajan Kopagade, and this team, and especially the Health Minister, Shailija Madam, to make this conference or this platform for the dissemination of the knowledge and getting information, international, national, and the other experiences to move forward for the later on to that. Thank you very much for giving me an opportunity. Thank you.
Applied diarrheal disease research, which resulted in hundreds of published papers. And he's the senior editor of the book, WHO book of Case Book of Ethical Issues in International Health Research. And in TB DOTS program, he is known for his making history by the community-based solutions for million, making tuberculosis history. And he's a visiting professor of various universities and various places, which include our own Achyuta Menon Center for Health Sciences in Trivandrum, which he visits whenever he gets an opportunity. Over to you, Dr. Richard Cash.
Well, thank you very, very much for that kind introduction. I wonder if can you all see me? Am I visible to you all? Can you hear me? Okay. Well, let me thank the organizers, first of all, for putting together such an exciting program. It's a huge honor for me to be able to attend and to return to Kerala, even though virtually. I have very fond memories of spending time teaching at the Achutha Menon Center and continue to maintain friendships and relationships with people in Kerala. I thought the previous speaker gave us a really excellent discussion of what has happened in terms of IMR in Kerala. And rather than repeat that, I thought I would take a somewhat view from above and take a look at this issue from a more global perspective. I first came to South Asia in 1967 when I joined the ICDDRB, or actually it was then the Cholera Research Laboratory, and to do work which eventually led to the development and testing of oral rehydration therapy. When I first came to Dhaka, the infant mortality rate was about 150. And now, 53 years later, it's down to about 26, with an under 5 mortality of 31. The maternal mortality rate, which is much more difficult to lower, was in the 800s and is now down to about 150, 160. So how did all of this take place within such a short period of time? And the same thing has happened in many other areas of India. Well, first of all, there is the proximal determinants. High rates of immunization, including immunization of mothers for tetanus, with tetanus toxoid. There were wards of patients with tetanus when I first joined 53 years ago. Low-cost treatments, oral rehydration therapy, for example. Nutritional inputs, both with certain vitamins, folic acid for women and vitamin A for certain children. Increased primary health care with a huge increase in the number of health manpower and the availability of drugs and treatment, many of which, of course, are given inappropriately, but some actually hit the mark. Better birth attendance, better MCH factors, and so on. All of these have contributed. And as we have watched the infant mortality, it has gone down steadily. It hasn't suddenly precipitously dropped, but it's been a steady downhill look. But then we have to look at all of the distal determinants, all of those factors outside of the health system. Better roads, electricity, a huge input from maternal education, women's education, particularly at the primary school level, women's empowerment, women in the workforce, age of marriage going up, and then in the health sector again, family planning, birth spacing, age of marriage increasing, agriculture. All of these are what I would call distal determinants. So it's a steady downward movement. I looked at this back when I was a visiting professor in Japan, and it went through the same process, although there weren't immunizations in those days. This began about 1918, and they had reached parity with the United States by 1965. So the same slow process takes place. What I think is very critical here is that it did not depend on the health care system, but on the system of preventive medicine and other determinants of health. And I think that this is very important. The health system itself can take us so far, but then much of the improvement must come through all of these other factors. Now, Kerala, as you have just heard, has done a remarkable job in so many areas, not just of health prevention, but also in issues of literacy, almost 100% literacy, issues of women's empowerment, better roads. I remember the first time I came to Kerala, I was really struck by how everything was interconnected to everything else. Water, sanitation. I remember taking students up to the Tata Tea Estates in Munnar, which had achieved, even though people were still living in the same line houses that they had lived in before. And when infant mortality and so on was astronomical, this had all come down through a really, really excellent system of both primary care and also immunization rates and so on. And for those of you who've never been up there, to see the system up in Munnar was just very, very exciting. But other things, education of the girls, postnatal care, breastfeeding, all of these factors came into play, which were absolutely critical. Now, so I don't want to overstress the Kerala situation, because all of you have heard about it. But as I say, within Kerala itself, there are also very, very exciting experiments that, and not experiments, but implementations that have gone on through the years. And again, Munnar is a classic example of this, which was a wonderful template for others looking to improve their primary healthcare system. But then what do we compare Kerala to? What is the comparator? I often see papers where Kerala is compared to the US, a very bad comparison, by the way. Kerala spends about $150 per person. The US spends $10,600 per person. And the infant mortality rate, by the way, is almost identical. But the other comparators that people have mentioned is certainly Sri Lanka. Sri Lanka, although it has a slightly different healthcare system, much more government-oriented, still the other factors, education, status of women, roads, electricity, all of those other distal determinants are very, very similar to Kerala. And also within Asia, Malaysia, as people have mentioned, Thailand. I think if Kerala is to take lessons from anywhere, it's from the east that it should look, and it's south rather than to the west. I remember when I first visited the Kerala Museum in Trivandrum, how many of the artifacts in the museum were actually from Indonesia, Sri Lanka, and so on, not from the north of the country, but Kerala was always looking south to its through its trade routes and so on. And I believe that that in the future, in terms of increasingly improving its position, which is really quite remarkable. As I note, your infant mortality is not much different from the US. UK is 4, and so on. So you should be justly proud of what you have achieved, but you will achieve greater lowering, if that is your goal, of course, is in those factors outside of the low-cost primary health care interventions. It will not be through high-level tertiary care. That will not lead to a dramatic lowering, but is through the steady, slow economic, social, political development that it will come about. And it is through that it has come about. I think I will stop my comments there and look forward to the comments of the others, and to thank the speakers who preceded me with such an excellent discussion of IMR in Kerala. Thank you very much.
Thank you, Dr. Cash. Our next speaker would be Dr. Vivek Virender Singh, who is a health specialist with UNICEF, which is coordinating the health systems policy and program interventions for child health at UNICEF India country office. He has been instrumental in national implementation of National Polio Surveillance Project of India, and also in Africa, especially in Kenya's expanded program of immunization and polio eradication program. He's a faculty of Indian Institute of Public Health, which is engaged in the development of course content for competency-based training programs. And he is involved in the public health surveillance, public health program management, policy advice to the state governments, and planning of maternal and child health programs. He has worked in public health emergencies and also in strengthening early warning and response systems globally. Over to you, Dr. Vivek Virendra Singh.
Thank you, sir. Am I audible? Thank you for that generous introduction, sir. And I'm honored as UNICEF as well. We are honored to be associated with this conference, and the Honorable Health Minister and other dignitaries present here today. So at the outset, as Professor Cash also mentioned, that our previous speakers have made our job in this panel easy. And I would pick up on the title, the SDGs, Dream or a Reality, and put things in perspective for Kerala. I want to share some slide pointers that I have. Can anybody confirm if my slides are visible?
Yeah, visible.
Thank you, sir. So as I said earlier, that we have heard from our speakers throughout the conference, and everybody is trying to put things in perspective for Kerala. But let me point this out at the outset, that Kerala as a state in India should also have lessons from Kerala. So more than, what are the benchmarks and standards for a state that has already reached the aspiration of India in the India Newborn Action Plan of a single digit NMR, for example, a decade ahead of time. So while it should set its own benchmarks and standards, I think there is a lot that the other states in the country as well as the region should also learn from Kerala. Now, everybody has mentioned about this, that we have seen during the Millennium Development Goals, the amount of reduction that we saw in the infant and maternal mortality. Probably what we are not going to see, because as it gets lower, we are not going to see this and during the SDG period. And this is the time when it will be difficult for every incremental gain that we want to achieve. So I think this was a fair comparison when we heard that if we want to compare the health systems in Kerala, in the region, to Sri Lanka for various reasons, and as Professor Cash also rightly mentioned. But having mentioned Thailand, we must also acknowledge the fact, and I heard Dr. Virod from Thailand in the conference, that with this kind of an event of Kerala conference, I compare it to the annual event that Thailand has, which is called the Prince Mahidol Awards Conference. And it's a global diplomacy event where Thailand, with its public health system, with its achievement in universal health coverage in the region, is able to take the lessons to other countries and also bring about some very useful changes through the World Health Assembly. For example, we all know that Thailand's work around human resource for health and some of the interventions they have been able to make are quite well known. So I think this kind of interaction that we see during this conference of our fraternity colleagues from countries like Thailand coming in is very welcoming. Now, again, just to re-emphasize on the point that we have seen the decline after the advent of National Rural Health Mission and the fiscal and other resources inputs that we started seeing in health. And if we remember the idea, the ethos behind National Rural Health Mission when it started in India was commutization, taking health to the people. And I think that is where the social model of Kerala has been successful of what India envisioned to do as a state. We have seen that what that can do to the health indicators, and we have seen the corresponding decrease in Kerala. Now, coming to the core subject, maternal child health, SDGs, whether dream or reality. So we have heard enough about the global level. Now let's come to the India level. And one of the speakers in a panel, Dr. Rakhi, who will be speaking shortly. So one of the work published by the Global Burden of Disease India chapter, which does the state disease burden, recently they just published a 17-year trend of what are some of the districts in the country that might, at the given annual rate of decline, might not be able to achieve the SDGs. This does not mean that they will not, but this just means that they will have to do things differently, and they will have to do things differently at a scale to be able to meet the targets. Now, as we have seen, that causes of newborn deaths, which is 8 out of 10 in Kerala, 80% as well. For a state like Kerala, now the state disease burden group gives us the opportunity. For example, if you see the highlighted portion, and not surprisingly, as our previous speakers have also mentioned, we see the increasing congenital malformations and the neonatal preterm births, and the mortality due to these cohorts increasing as the NMR reaches the single digit. Now, here is one point that I want to make, and let me pick from what Dr. Kamath was speaking in the previous intervention, where he said that every child should celebrate its first birthday is what Kerala should look at. I would add that let us pledge that now, if the infant mortality has already reached 10 and the newborn mortality has reached 8, let us now pledge that every child does not just see the first birthday, but sees the first birthday with best of developmental milestones. And I think that's the next step which states and countries like Kerala that have achieved low newborn mortality should reach out to, for making sure that each of these premature babies who, because of our system's ability to make them survive, have survived, they also develop to their best possible potential. And that is where taking the agenda from just the survive to survive and thrive comes in. So I think this is one area where states like Kerala can inform others. Now, another important point, when I mentioned that in states like Kerala, we need to take these lessons to other states. So if you see that, as for example, again, taking the case of newborn mortality, if we club the states according to the current NMR, we see that, let's say, single digit NMR in the green, if you see. So what are the kind of interventions you would need to further reduce? So high risk referrals, are we identifying the high risk kids, referring them properly? Further strengthening of the tertiary care, maybe congenital malformation specific things that we all know need to be done, pediatric surgery, competent nursing. Now, this is something where I want to pick that last year was declared to nurses and midwives in India, and a lot of these gains are now going to come from the competence of our nurses in these specialized care settings. And I would also further add that, perinatology as a specialty, both for physicians and nurses, which the other states who are still high burden might not be, where there is still making up for the skilled attendance at birth. So where there is less scope of trying such specialities, states like Kerala can do it. But the most important point that I want to make is that when we see in these boxes, what are the additional incremental gains that are going to come by these interventions, it does not mean that everything else which is mentioned for high NMR states should not be done. So that plus this, which means that you will have to continue reaching those newborns, reaching those kids, reaching those mothers at home during the antenatal period for the mothers, postnatal period for the mother and the baby, both. Now, how do we achieve it? The recent Lancet Commission, which said, what is the high quality health system which can help achieve the SDGs in the SDG era. And this is again where there are both lessons for and from Kerala that can come. We all know the social security and other community empowerment, local governance type of actions in the states like Kerala. Now, here is the opportune time for high quality in our health system, where quality impacts from the perception side of the community is given equal importance. And it is based on population health needs. And we need to do transformative actions for workforce and reimagining our service delivery platforms. Because once we have reached these stages, the next gains are going to come from our equity focus. That are we missing those that will continue to be missed, as you said, maybe when we see a stagnant line for almost a decade. So our next focus should definitely be equity. And in the same Lancet paper, if you look at people who bypassed the public system and who cited at least one quality concern, so we also see that there were samples drawn from all the states in India, and there could be lessons for everyone. Then another important point for such states is that making UHC a reality for SDGs. Although universal health coverage is one of the components within the SDGs, but let's look at it upside down, that with UHC, we can only achieve the health-related SDGs. And it's not surprising if you see in the highlight box where I've tried to show India with the Iceland, Israel, Italy, some of these developed countries in Japan. Not surprisingly, you see all of them in blue, whereas for many of the service coverage indicators which were drawn for this UHC index, India, we see a lot of scope for improvement in many of these. And similar indices, I think the states can also continue looking at to see how they are performing. And then what are some of the actions for these high quality health systems, as we are calling it? So foundation again, and some of the things which are good in Kerala, that govern for quality at all levels. Now that people are coming to services 100%, as we heard from the previous speakers, are we delivering these services with absolute perfect quality? Redesigning service delivery to reach the unreached if there are equity issues. Transform your health workforce, maybe more midwives, to have these services nearest to the community as possible, the ethos of primary healthcare. And then population, ignite the demand for quality. People should come forward, and we could strengthen in community outreach, primary care, hospitals, emergency medical services, and referral. And I think states like Kerala can focus on referral and emergency medical services, which are still catching up a lot in other states. And some of the final points, and I think enough has been said, but it's worth re-emphasizing the fact that it's only through the primary healthcare approach, which has three distinct approaches within PHC, that integrated health services with absolutely well-aligned referral, with an emphasis on primary care and essential public health functions within the health workforce available to the communities as near to them as possible. Then empowered people and communities, which I think is a very good background already in states like Kerala. And then multi-sectoral policy and actions. So I think drawing again what Professor Akash said, that if we remember, there was a call given, health in every policy. So, in fact, there's a write-up also by a lot of eminent members from India that wrote about health in every policy, the same WHO principle which was given around that time. So focusing on the primary healthcare, and as I mentioned that in Kerala, we can try out things like perinatology, maybe strengthening the midwifery cadre, the nurses on the front lines for these. And finally, I just want to remind that, when India set up the India Newborn Action Plan in 2014 in global response to the Every Newborn Action Plan, India, in fact, was more ambitious than the global targets and said we would want to achieve single-digit NMR 5 years ahead of the global timeline, which is SDG 12, but India has 10 by 2030 in INAP. And what I want to remind the audience here is that Kerala was already under 10 when INAP was being formed. but there is a component within an INAP and vision where we can still work in states where we have such low NMR, which is if India envisions a health system that eliminates preventable deaths of newborns and stillbirth, and where every pregnancy is wanted. So the importance of birth preparedness, as somebody rightly mentioned, that newer issues like mental health in mothers. So if we are working with the mothers for birth preparedness, which was such a basic thing, we will catch up with these new kind of issues that are emerging during that birth preparedness process. So where every pregnancy is wanted, where every birth is celebrated, and where women, babies, and children survive, thrive, and reach their full potential. Last but not the least, we have seen what COVID can do, and I deliberately did not bring that point up because we all are still studying as states and countries the impact it has had. So let us not forget that for the SDGs to make this dream a reality, and yes, it can be done, this decade was already declared a decade of action before COVID happened. And how will we be able to achieve these global goals? By mobilizing everyone and everywhere. And I think COVID response and in states like Kerala has shown the importance of whole of society approach. And I see the professional associations also represented and speaking in the conference. So mobilize everyone, everywhere, and demand urgency and ambitions, because we'll have to redouble our efforts in this decade of action because of the regression that COVID has brought about, and design new innovations and be pragmatic in these new innovations. Thank you very much.
Thank you, Dr. Vivek Virendra Singh. Let's move on to the next session. This is by Dr. Ahmed Reza Hoseinpour. He's the Health Equity Monitoring Lead at WHO Geneva. He has conceptualized and coordinated the development of resources and tools in this area, including the unique tool HEAT, which stands for Health Equity Assessment Toolkit, a software application to explore and compare health inequalities. And he's involved in the WHO Handbook on Health Inequality Monitoring. And he's the lead author of a number of peer-reviewed articles quantifying the inequalities in health, both in country level and global level. And he's very enthusiastic to use the interactive data visualization in order to effectively communicate health data with diverse target audiences, which is showcased in many WHO global reports. Over to you, Dr. Reza Hoseinpour.
Hello, everyone. Thanks very much, sir. So it's a great pleasure to be here and to talk about inequality monitoring. And my talk today has two parts. In the first part, I'm going to give you a short presentation on importance of inequality monitoring with a couple of examples, as also came up nicely by Dr. Vivek just in the previous talk. And also then give you a live demonstration of a toolkit that we have developed to assess situation of inequality in countries. And we are going to showcase India as an example. So equity is at the central of Sustainable Development Agenda with the aspiration of leave one no one behind. And it's already reflected in several SDGs. SDG 10, of course, is the main one to just reduce inequality within and between countries, but also it's reflected in SDG 1, 4, 5, and 3, of course, health. And we have the target 17.18, which calls for building capacity for disaggregated data in countries that are reliable, timely, and high quality. So recognizing the importance of inequality monitoring and data disaggregation for equity-oriented policies, programs, and practices, WHO has developed tools and resources to support countries for monitoring of health inequality with collecting, analyzing, and reporting on disaggregated data. So I'm going to give you a couple of examples here. The first one is WHO Health Equity Monitor, which is one of the largest equity database globally. And this database is developed and launched in 2013 and has been updated annually. And currently, it includes over 30 health indicators, mainly from the domain of reproductive, maternal, and child health, disaggregated by 6 dimensions of inequality: economic status, education, urban, rural, subnational region, and age and sex wherever applicable, based on reanalysis of more than 450 international household surveys, which were collected over past 3 decades in 118 countries. And they are interactive visualizations and country profiles there. The second example that I'm going to give you is the toolkit, Health Equity Assessment Toolkit, that I'm going to just share with you a live demonstration of that quickly. So here is the toolkit, Health Equity Assessment Toolkit. Just checking with you, can you see my screen, please?
Yes, we can see.
Okay, perfect. So Health Equity Assessment Toolkit is around 2 concepts, 2 areas: explore inequality and compare inequality. In explore inequality, we are going to look at the situation of inequality in a country of interest in terms of its latest status and change over time. And in compare inequality, we're going to compare the situation of inequality of one country of interest with other countries. So let's start with explore inequality and looking at disaggregated data. As you can see it here, there are several tabs on the right side, which I'm going to just show it, just some examples of that. And on the left-hand side, we can see a selection panel. That from that selection panel, we can pick up the country of interest. So I can here just go and pick up India. And you can see we can define surveys or data sources we have, different years, and also we can define different indicators here. So here, currently in the current view, we're looking at a stillbirth attendance in India over 3 periods for which we have publicly available data from National Family Health Family Survey, NFHS, in 1998, 2005, and 2015 from Health Equity Monitor database that I just described for you. And we can see here on the x-axis, the coverage of a stillbirth attendance from 0 to 100%, and in y-axis, the year of the survey. And we can define here different dimensions of inequality. So for example, I can pick up economic status just only disaggregated by 5 quintiles. So This is known as wealth quintile. And we can see here for each survey, for each year, we can have 5 data points showing the coverage of a skilled birth attendance in each of the wealth quintile, from poorest quintile to the richest quintile. And we can see here in 1998 and even in 2005, there was a large gap between poorest quintile and richest quintile in terms of a skilled birth attendance. But the good news is that in the latest survey in 2015, the gap between poorest and richest has decreased quite significantly. Of course, as we can see here, still there is a relatively large gap that requires to be increased. From left panel, we can pick up other indicators from that list. So for example, if we consider skilled birth attendance as an indicator, proxy indicator for maternal mortality, let's pick up an immunization indicator. So DTP3 immunization coverage that influences infant mortality. So here we can look at infant mortality. We can look at DTP3 immunization coverage by wealth quintile. And as we can see again, there was relatively large gap between poorest and richest in the previous surveys. But in 2015, in the latest survey, the gap decreased significantly. We can also pick up different dimensions of inequality like education and place of residence. So immediately with this interactive visualization, we can capture the situation in the country quickly in terms of different health programs and also different dimensions of inequality. For example, for DTP3 immunization coverage, we can see in 2015, there is almost no difference between urban and rural areas. We can look at it from different angles, this sort of visualization. So for example, if we're interested to see what are the differences between the states in India, we can go to the horizontal bar here, and we can see the situation in different states. So we can also sort it by, let's say, different indicator, let's say by a skilled birth attendance, and so on. And we can also look at compare inequality. So not only we can see the situation of within country inequality in India, we can see where India stands in terms of inequality comparing to other similar countries. So the toolkit by default picks up the same income group countries and the countries from the same region. So low middle income, Southeast Asia was taken. And if we look at the benchmarking, the comparing inequality here, we can see while by itself there was a large inequality, wealth-related inequality for a skilled birth attendance, comparing to other countries in the region that had data more or less the same time, 2014 or 16, similar to India, then other countries had much larger inequality. So it always helps to look at benchmarking to see where the situation of inequality stands. We can also look at it in another view, because we always say national average is also quite important. So in this view, we're looking at a skilled birth attendance again, and in the x-axis we have national average of countries, and in y-axis we're looking at inequality within country. In this case, the difference between poorest and richest quintile in each of these countries. And we can see that in terms of national average and within country inequality, India is doing quite well in the sense that this area shows the area that has larger national average and lower inequality. So we can also highlight different countries, naming them, and we can add to the situation. And always with the tool, we can also download the data as a visual, as a image or PDF and put them in the reports, or download the data that is behind that. So that's just showcasing the situation that we have in our health equity monitor database. But also the point is that the toolkit has another version, which is called Heat Plus. And with that version, we can see the situation in terms of different data sources that we have. So the toolkit that is called Heat Plus, users can upload their own data. So if we have data at subnational level, let's say within each state, we have data that also can be uploaded. And instead of comparing situation of India as a country with other countries, we can look at the situation of Kerala in terms of inequality, comparing it with other states. Or if we have more data, even at district level, we can compare inequality at district level within Kerala with the tool. So the point is that what we would like to do is that to make sure we know about the situation of the disadvantaged population, and that's important for the planning. So with using this tool, we can plan for that, and we can see what are the points that requires priority and action. The toolkit can work also not only with surveys, but also with different data sources like facility data, CRVS, and also census data. And as I said, it could be used at any subnational level. And broadly speaking, it can use any health, any indicators, health or beyond health. So can also look at different determinants of health and look at disaggregation of those tools as well. Thanks very much.
Thank you, Dr. Ahmed Reza. Let's move on to the next session, and that is going to be the last session of this panel discussion. Let me welcome Professor Rakhi Dandona, who is a professor at Public Health Foundation of India and professor of Health Metrics Sciences at the Institute of Health Metrics and Evaluation, University of Washington, US. Dandona has over 2 decades of experience generating evidence on disease burden and risk factor distribution at the population level through epidemiological studies. Professor Dandona is the chair of Global Burden of Disease Study in India, Injury Expert Group for India, State Level Disease Burden Initiative, collaboration between ICMR and in fact more than 100 other institutes. The initiative's research on gender differentials in suicide has received a lot of reviews. Her work as part of evaluation of large-scale neonatal health interventions in Indian states of Bihar and Uttar Pradesh has generated robust evidence for stillbirth estimation and health system-related risk factors for stillbirths in India. She has had several researches funded by grants and has more than 200 peer-reviewed publications. She is the associate editor for Journal of Injury Prevention and serves as in the editorial advisory board of Lancet Psychiatry. Over to Dr. Raki Dandona.
Thank you very much for that kind introduction. I hope I am audible.
Yes, you are audible.
Wonderful. Thank you so much. Thank you. I must say that, you know, given that my primary work is a lot in Bihar and Uttar Pradesh, and I'm so used to dealing with mortality statistics that are double digit, you know, this presentation for Kerala was a very unique and very proud experience where we are talking about single digit numbers within India. So very pleased to be part of this panel. Thank you very much for inviting me. My presentation is built around, you know, what we know of infant mortality and neonatal mortality and what evidence do we need more to reduce it further from the single digits that we already have. The overview of the presentation, I'll take you through the mortality burden, inequity as we understand, cause of death, and then lastly talk about morbidity as many of these babies continue to survive. The under 5 mortality in, these are the SRS numbers, is 10 currently in Kerala. This is the IMR and this is the NMR. So if you look at the proportion of NMR now within the IMR, that's about 70%. And IMR within under 5 mortality is about 70%. So the idea is that if we work more on NMR, reducing NMR, our IMR is likely to come down much faster than we keep it as IMR as a broad category. What do we understand in terms of inequity? Inequity we can see in many different ways. One is looking at inequity in terms of geography. SRS tells us there is slight inequity, but this is not significant between rural and urban parts of Kerala, which is 5 and 7 respectively. We know from, I think Dr. Vivek Singh mentioned that our group has done this work of district level estimation for under 5 mortality and neonatal mortality, which was published in Lancet last year. If you look at this, these are all districts of India. The more red they are, the worse off they are. And it's very interesting to see, as all of us know, the blue parts are basically centered around Kerala when you look at under 5 mortality or you look at neonatal mortality. Now, if you look at this in detail from the Global Burden of Disease study, we see that the variation even within the districts of Kerala is actually not much. And the variation that you see is actually statistically not significant because the confidence intervals overlap. Having said that, it's important to know that these are all modeled estimates because we do not have robust estimates for district level, you know, primary data availability for district level at population level in India. This is the gender differential for IMR. As you know, SRS does not give gender-based data for neonatal mortality, but here clearly the gender differential is seen where the IMR is higher for boys than for girls. We do not have differentials available by social groups other than, of course, what the population-based surveys, for example, like NFHS give us. But the issues with those data are that the sample size is not enough for us to robustly estimate the actual differences between the social groups for IMR or for NMR. But we would need social groups, the differences by caste, by socio-economic strata, or whatever is relevant social group that is applicable to Kerala. We would also need robust estimates by place of delivery, public sector and private sector. NFHS 5 tells us that about 40% of the deliveries in Kerala is in public sector and the rest in private. So it would be interesting to understand how the IMR differs by their place of delivery. And of course, by gestation period, given that preterm births are an important contributor to the IMR in Kerala. One way to build evidence around these social groups is from the health facility data. Given that most of the births, almost all of the births in Kerala happen in health facility, we need to integrate data variables across these groups and what else we need within the health facility data and start looking at those data to understand what do we find as differentials by the social groups or by place of delivery or by gestation and other clinical factors. And given everything is mostly computerized health facility data, these are the kind of differences that we have to make now. Start using these data for this single digit IMR and NMR to reduce further. There's only so much that we can make a difference now in these numbers based on, or these rates based on population level data such as NFHS. If we were to assess population-based data, which has its own contribution and own risk factor assessment, we would then need much larger sample sizes, robust surveys for a given period, and collect data on recent births. For example, NFHS takes births in the last 5 years, where the sample for recent births is really small. So we would need population-based data for recent births, large enough samples, which we can establish baseline and population level for these differentials that you see here, and then use that for improving changes that are needed further. Cause of death, many of the previous speakers have talked about cause of death. I won't spend much time on what the differences are. The differences are fairly visible, where congenital birth defects really are a big concern in Kerala, which is true in other developed country settings as well, as you take care of more of these infectious and other perinatal conditions. If you look at this a bit more in detail as we go down, urban, rural, the difference is not as much. But here is that difference by neonatal deaths. If I remember, I had mentioned that 70% of IMR is neonatal mortality in Kerala. So if you look at neonatal deaths, most of them are here, the neonatal disorders, the preterm births, the birth asphyxia, and trauma. And this attention on this, along with attention on congenital birth defects, is where we need to go. The activities that are already happening in Kerala, the strategies that are already in place, are in any case built towards addressing these causes of death. And in fact, even much more than what one would have anticipated. The activities that are currently on are actually fantastic. What we now need to do, if we need to go down further, is to start looking at this cause of death by, what are these potentially avoidable causes of death? And how are these causes of death influenced by the conditions that are in the population or in the community? To do that, I've broken it into two, the facility-based evidence and the population-based evidence. Facility-based evidence, we now need to start looking at, just not look at the death reviews, the maternal death reviews or the child death reviews or the neonatal death reviews. We need to start looking at the clinical risk factors across all births and to see which of these births are likely to die, because you have the live births and you have the births who've died. So the understanding of risk factors now is needed across all live births and clinical risk factors, which is why NFHS is not going to help us much here, because NFHS does not collect clinical risk factors, which is where we have the importance of strengthening the clinical documentation for each case, so that we can start looking at clinical risk factors to see how we can change what is needed at the facility to make sure that these babies survive. Similarly, at population level, I've already mentioned, we need baseline assessments that actually allow us a baseline assessment to understand what the risk factors and inequity are at this point in time, which we can then, in collaboration with facility evidence, use it to find the policy that we actually need for disease prevention. One of the important things to go further down to reduce the mortality is to understand the cause of death better. The cause of death, medically certified cause of death in India happens only for less than 25% of the deaths, and Kerala is actually around 12%. Medically certified cause of death will take us really in that direction of understanding what actually needs to be done, because verbal autopsies can only tell us this much. Even within the verbal autopsies that we use currently, there are standard forms available. For example, the World Health Organization's verbal autopsy form or the PHMRC form, which allow us to generate standardized data which allow us to generate the cause of death in a more standardized manner, so that Kerala can actually compare its cause of death over time within Kerala and also with other similar settings using verbal autopsies. So cause of death needs improved documentation. The other way to look at cause of death is also, as we are doing verbal autopsies, as we are trying to understand why these babies are dying, to keep an eye out for symptoms, signs, and abnormal findings that don't fit anywhere. For example, sudden infant death syndrome. Many of us have started to hear about it. Many of us have started to talk about it. For example, in our primary work in Bihar and UP, mothers simply tell us in verbal autopsy, baby had milk and baby slept and baby never woke up. Baby was all fine. So there are ways to start accumulating evidence for even causes like SIDS, and there are verbal autopsy ways of doing that. So I think Kerala needs to start building evidence around these emerging causes as well. Stillbirths is kind of missing from the agenda. We've talked about MMR, we've talked about NMR, but there's also stillbirths. These are babies who are nearly full term. There's a definition for stillbirths, beyond 7 months of gestation. And the rate of stillbirths in Kerala is not that different from the rate of neonatal mortality. So as Kerala starts to work towards reducing NMR and IMR lower, I think Kerala could also start focusing on how to reduce the stillbirth rate further, because many of these stillbirths are actually preventable. Lastly, if this is what I saw in the ebook, and Kerala is already doing fantastic in times to see how to address these causes of death, which are very different from what the other Indian states do. But as we continue to see these causes of death, and some previous speakers have also mentioned, we would need a variety of specialists. And if you look at this figure here, it clearly shows that you also need an ophthalmologist in addition to someone who's specializing in delivery and antenatal care. You also need someone who's a hearing expert, and there would be much more specialist needs as we continue to make sure that these babies actually survive and not die. The health system needs to be integrated. It cannot simply be a delivery system as these babies survive. It would need rehabilitation and disability along with the delivery services. So survival and rehabilitation and quality of life has to be built in. The health system needs to become a child-friendly space, because these children will need more access and more space to visit health system for maintaining their quality of life. And of course, the access needs to be closer to home. This also means that the kind of research that we do in Kerala starts to become different. The research in Kerala needs to work across a variety of these issues so that it can actually reduce the mortality further. And I did hear some of this already in some of the previous presentations, but I think as a policy program perspective, we need to invest more in across each of these to make sure that the numbers go down further. Lastly, all this is also going to change community level needs. After we talk about mortality, we need to start talking about morbidity. These babies will survive. More of these babies will survive. So the community participation in all the actions is very important. The community perception and integration of these babies into the community is very important. And I say this because we do understand, already issues with integration of people who live with disability. The child care services, education, and welfare services would need to expand to make sure that these babies have good quality of life. Thank you.
നമ്മുടെ ബഹുമാനപ്പെട്ട our Minister for Health is joining us. I invite our Honorable Minister for Health, Shailaja teacher, to address us and address the panelists who are online now. Madam.
Yes. Dear friends, I want to express my immense pleasure to the speakers who correctly introduced or explained the actual facts about the MMR and IMR reduction. And as you explained here, Kerala also declared our goals for MMR and IMR reduction. These indices actually points out the health, actually importance of health. And in Kerala, according to the Sustainable Development Goal, we also declared our goals on MMR and IMR reduction. When we examined in 2016, the IMR in Kerala is 12 out of 1,000 live birth. But we started to, or we declared the aim to reduce it to single digit. And I'm very happy to see that the IMR reduced it to 7, that is declared in 2019. And now the NFHS survey, latest survey shows that it go below 5. We should examine it properly, and we can say that now we are in single digit and we want to reduce it more. And MMR also, the central government declared to achieve the aim of the UN goal, Sustainable Development Goal, that reduce the MMR up to 70 by 2030. And Kerala declared 30 by 20 and 20 by 30. That was our aim at that time. And we worked hard on that. And when 2016, when we examined, our MMR is 67 in 2016. But it reduced to 43 when we examined in 2020. And the central government gives some certificates on that. And we got 2 certificates. One is for reducing the MMR below the declared aim of the UN, and also to achieving the lowest MMR rate in India. And that is also a very good achievement in health sector. But as the speakers, I didn't listen to everybody, but I listened to Dr. VP Paili and also Dr. Kamath, but I was too busy today and I can't listen to everybody. And I left the meeting when Vivek Virendra started his speech, and I cannot listen to everybody. But Kerala is doing so many measures to reduce MMR and IMR. The delivery points, that is the most important thing, and we strengthened our delivery points according to the Lakshya standards. Central government declared the Lakshya standard for the delivery points, and we started to improve our delivery points in Lakshya standards. And also we declared so many projects to reduce MMR and IMR reduction, especially for IMR, the Hridayam project, as the speakers mentioned here, that to address the congenital heart disease and the congenital diseases. And that also became a good achievement to reduce the infant mortality rate. We had already done more than 1,600 operations under this project, and most of the operations, 99%, it become success. And that way also we were able to reduce the infant mortality rate. And for the mental health also, I think the maternal mortality, it happened because there are so many reasons, but the NCD has an important role on that the hypertension, diabetes, etc. Now we are trying to reduce the NCD also, and that way also we can reduce the maternal mortality rate. And the mental health, it is also an important thing. and we are giving counseling and classes to these pregnant mothers, and we are listening to their mental health also. And so many measures we have adopted during these 5 years, and I think we can achieve more good results out of that. I am not elaborating everything, and we have to stop this session in time. And I will listen to your points, and I will get the webinar discussion points from my health secretary and the organizers. And I think we can implement more fruitful things to reduce infant mortality and maternal mortality in future. We can reduce more, and this part also Kerala can become a model to reduce the maternal mortality rate below 20 by 30. That was our aim. And infant mortality rate below 5, I think we can achieve that results in future. Thank you everybody to participate in this seminar, this webinar. And Kerala is looking for the solution for all the health problems, including infectious disease and also NCD control, everything. And with hope, I congratulate and I extend my thanks to all the eminent speakers in the webinar. Thank you all.
Thank you, madam, for sparing time from your busy schedule. We'll go on to the discussion part, which is going to be very short because of time constraints. The HEAT, or that software, that program, that is new to most of us. So I was just listening to that. So whether we can apply to a Kerala situation also, like we have inequality, although inequality is minimum in Kerala as compared to other states of India, there are still inequalities possible, say for example, tribal. So whether we can actually capture that with that program or software. So can Dr. Amdar Reza please enlighten us?
Sure. Thanks much. Yes, of course. And that's the whole point of having this software application. It has 2 editions, and the edition that is called HEAT Plus basically allows users to upload their own data to the toolkit. And in that sense, the data can be from any level, could be national, but also could be subnational at the state level and below that, district level. And it could also be from surveys, but also from facility data or CRVS or census, or a combination of that. So we did a couple of years ago we worked with Indonesia, and we used different data sources that they had to look at inequality in Indonesia. So in that sense, yes, any data that you have, so that's the flexibility of the tool that can be used. And I can also share with you in the presentation where you can get that. So that's on the WHO website, and perhaps one easy way to just look at it is to Google it for WHO and Health Equity Assessment Toolkit. But I'm happy also to share with you the link, which has also all the documentations, user manuals, and some training videos on how to use it. But to shortly answer you, yes, it's totally feasible, and we already done some work using NFHS 5, which is also a state level representative to look at inequality in Kerala and comparing it with other states. So it's totally possible.
Thank you, sir. And thank you, Dr. Raki, for enlightening us on which are the areas to concentrate on, because the NMR is the major share of mortality. So how to actually plug the possible gaps from the experience of working in various countries and various associations, in which area should we actually concentrate on? Rakhi ma'am?
Thank you. Thank you for that question. I think in terms of area, I would put it more as a thematic area. I think we should concentrate on facility, given that most of your births are in facility, and start looking at the data by all live births. Just not look at the data in terms of only babies who die. I think that is what we now need to do to plug that gap. So we understand there would be babies with, let's say, risk factor A who survive, and there would be babies with the same risk factor who die. I think that is the kind of understanding we need to now have in Kerala to try to see where the gaps are and which gaps can be plugged immediately and which gaps would need a bit more of a mid and long-term strategy. So that kind of case, clinical data research or review would be needed.
Thank you, ma'am. And actually, we are doing an infant death audit every month. So we have some data on that. And when we are doing that, we come to a dead end when facing the SITs, because there only the verbal autopsy is possible. Is it the way the world over, or is there any other method? Autopsy, is it a common thing or a routine thing there?
It's not, verbal autopsy, or, they don't call it verbal autopsy, but yes, the conversation is what is typically done for SIDS routinely. The other way to also then, and these kind of conversations that have highlighted around the different parts of the world, that, there are issues with the way the baby sleeps, the issue in terms of, the side the baby sleeps, how the baby sleeps, with whom the baby sleeps. So these kind of conversations are the ones that will then allow us to understand what is the proportion of SIDS, but also what could be the risk factors that are, contributing to SIDS death. So at this stage, the conversations, whether we call it verbal autopsy or just having conversations, social autopsies for SIDS is the way to go.
Thank you, ma'am.
Thank you.
Accelerating the reduction of MMR and IMR in low and middle income countries has got socio-economic determinants coming in the way. So globally, how countries have tackled that? Professor Cash, can you elaborate on that, please?
Sure. Can you hear me or see me, or what
Yes.
would you?
Yes, I can hear you, sir.
My own feeling of looking at health over many years, and I mentioned the study we did in Japan and Bangladesh and elsewhere, is that the health of the population is a reflection of the values of the society, and whether society decides to invest in its population in terms of their education, housing, water, sanitation, and so on. Health is simply a reflection of that. And if you really want to reduce things like neonatal mortality and low birth weight, you have to attack it not at the facility level, but rather what happens to women who enter the reproductive age. So it begins when they're babies and through the system. And so I think that the values that a society has, and in Kerala, clearly there is a long history there's a very long history of social interventions, and it's why Kerala did so well in the whole COVID situation, is because it wasn't that you suddenly ramped up the system. The system was in place. The values were in place. The values of equity, making sure that the population was well served, and you don't do it when the crisis occurs. You build up to it over the years, and I think that in fact that is what has happened. It has to continue on, and the values of equity, the values of making sure that people have the maximum opportunities for growth and development physically and mentally and so on, should be intact. Unfortunately, in some countries, the health system tries to make up for the gap in what the social system should be providing. That's both very expensive, it's not very productive, and it won't get you where you want to go. So I think that Kerala and some of your neighbors have moved in that direction and should continue to do so. This does not require a sea change, but a continuation of what is already taking place. The high mortality and morbidity in some areas of the country are very much a reflection of the level of social development that has taken place in those areas. Not a health system which is not very good in some areas, but that's not where the problem is. The problem is far more in the investment in the people themselves. And I think history has shown us this. Thank you.
Thank you, sir. We have a few more questions, but I think those questions are already covered in the talk. And also we have used up the time allotted for this session. So thank you very much, my respected panelists. And with that, let me wind up this session. Thank you.
Thank you very much.
Thank you very much.
Yes, that was excellent. A big thanks to all the panelists and the moderator. And a special thanks to our Honorable Minister who proved that leadership is the ability to translate vision into reality. Now it's a time for us to hear from the field functionalities who worked in the field and to know how difficult or easy was their practical sessions to reach the top. I welcome Dr. Ramla Bivi, Director of Medical Education, Kerala, and Dr. Krishnaveni, who is the Reproductive and Child Health Officer, Kollam District, to share their experiences in the field in the reduction of maternal mortality rate.
Respected dignitaries in the studio, my dear other co-speakers, and the dignitaries who are listening this brief discussion on MMR all over the world, my dear students and colleagues. First of all, I extend my sincere thanks to our dear Paili sir for their excellent effort in reduction of maternal mortality rate in Kerala. So actually, my talk is continuation of his talk and what the field activities that we have done to achieve the goals. See, actually, the MMR reduction is not a single person's activity. It is a collaborative activity between the doctors and delivery points under Director of Medical Education and also private sector and the Director of Health Services. See, actually, it is happening under the greater banner of our Government of Kerala Health and also the KFOG. See, the role of KFOG has already been highlighted by our dear Paili sir. And it is implemented all over the institutions in the state. See, as said earlier, our Government of Kerala set our goals in 2018 as to attain the MMR of 30 by 2020 and 20 by 2030. So this is some of the data, important causes of maternal mortality, MMR, that has been already discussed by our Paili sir. I am not going into the details. See, actually this journey started in the early 2003. See, actually at that time, the only thing that is happening in the institutions and the district level is only confidential review into maternal death. That is simply called as CRMD. Then what happened is we have adopted the NICE guidelines and the quality standards were established in 2012 and 13. Then another important step that has happened in 2017 is maternal death near-miss surveillance and response. So following that, as Paili sir said, we have started an obstetric rapid response team in all institutions. The goals were clearly described by our Paili sir. Then training for all the type of categories of persons who are involved in the maternal care. Then we have the patient care has been driven by protocols which are already fixed and finalized by our teams. Then another important thing was auditing. So monthly institutional auditing, district level auditing, state level monitoring. And that happens at every month and at every intervals. That made a very big leap in achieving maternal mortality in our state. Then what has happened in medical colleges? Say medical colleges, you know, we are having 5 already existing medical colleges, 5 more upcoming medical colleges and new medical colleges. But in medical colleges across the state were all partners in achieving all the activities of to fulfill the maternity, to reduce the maternity mortality in the state, which includes training, then auditing and the protocol development. So since they are the experts, they are made an excellent effort to frame the protocol for the entire state, for the entire institutions. Then what has happened is we have to improve our infrastructure in a great deal, because when I was studying as an MBA student in Trivandrum Medical College, I am still remembering the status of our labor room, but it has changed much. So all the labor rooms in Kerala has been revamped to a larger extent. I had an opportunity to visit all the labor rooms across all medical colleges. That has immensely changed. So the entire atmosphere has been changed. Then another thing is there was actually no ICUs for maternal complications. So I am still remembering the first ICU I have set up in Medical College Alappuzha when it has been shifted from the town hospital to our new campus. So actually there was no earmarked space for ICUs for maternal complications. So we have, with the full effort, we have started ICU by the side of the labor room itself. So the ICUs has been completely modified, and also labor rooms also revamped. And another big leap is we are planning to start the separate maternal and child health block in all medical colleges. For example, in SAT, the National Rural Health Mission has funded in immense way to start a block. And already the Kottayam Medical College, we have started a separate maternal health block. Kolkot, we are already having it, but it has been strengthened. And Alleppey also it is coming up, and we are planning to start separate maternal health and child health blocks in all other medical colleges as well. Then another important thing that we have done is we are planning to do is forming a pregnancy teams that is condition based. For example, if a pregnant lady is having heart disease, there should be a particular person to look after that lady, that case. So that kind of pregnancy team development is happening in all hospitals, including our tertiary care centers. Then all the treatments should be a protocol driven one, and it has to be implemented in all institutions where the deliveries are going on. We are working for that also. Then another thing that is happening is a complete auditing of all the activities, including maternal death and reviews. Then this is one of the major leap that has helped in a big way to improve our labor room standards. That is implementation of Lexia standards. It is implemented through National Rural Health Mission. Actually, all the medical colleges initiated the activities, but because of the COVID, the activities have slowed down. We are planning to restart as well. Then the main purpose is we have to give a respectable care to our young mothers. And that we have to, another thing that we are planning is already implement is birth companions. So somebody should be there along with the pregnant mothers during the entire period of delivery. So actually I am happy to announce that in Government Medical College Kollam, we have successfully implemented this. And also I think it is in Punalur also it has been implemented. Then strict infection control practices. For that all measures have been taken in all institutions, and MMR with the help of our infection control units and nurses. Then standardized, we are bound to give standardized quality care. And also, of course, we have to strengthen our periphery in terms of infrastructure, in terms of manpower, in terms of all the facilities available. That is happening also. Then this is one of the proactive actions that has to be taken by KFOG. So the reduction of maternal mortality in the role of maternity, we have to special mention has to be done for K4Gs. That is their active participation and compilation and coordination. So that started in 2017 as confidential near-miss review, which actually started in 2017. After first phase, it was piloted in 5 medical colleges. In the first phase 2, what has happened is that there is we have collected so many data, we have compiled the data, and it has been submitted to the government. So that has been further ratified by the government itself. In phase 3, we actually started in January 2019. So it has been disseminated into our peripheral hospitals and district level hospitals. And then came the MD-NMSR, that is including private and government institutions. And there will be daily reviews, as I said earlier, the frequent daily reviews. With this, actually the reviews are happening at the headquarters level as well, under the leadership of our honorable secretaries and health, director of health services and the director of medical education and other dignitaries. Then all these activities and data are actually compiled by in the K4G's office. In this connection, I am giving a very big thanks and congratulations to our Dr. Bailey sir for his excellent leadership. So this is one of our district level MD-NMSR meetings. That is a fully filled hall with all observations in the district. This is some of the data that I am not going to the details. So the sum of my long-term plans, that is my simple thoughts. One thing is we have to, this is a pregnancy. As a time, we are getting a pregnant lady for 9 months with us. This is an ideal time to screen for medical disorders and implement preventive strategies for reduction in these NCDs. So this period has to be effectively used. And develop high-risk pregnancy-specific think tanks and centers of excellence to effect accessible and affordable quality in maternal health, to generate correct and specific data. So this is the area where we have to strengthen and we have to go for. With the implementation of e-health activities, I think it will be very easy for us to compilation of data. Then only we can formulate the protocols and policies. Then we have to be able to provide comfortable, respectful birthing practices across the state and bring about declining cesarean sections. That is another motto. Then another thing is to formulate an effective and referral protocols for the state. These are our long-term plans. I think when we work together, we can achieve the goal of maternal mortality by 2030. Thank you, sir, for excellent. Thanks for the patient hearing as well. Thank you.
Sorry. Respected dignitaries, I just wanted to brief some of the initiatives which we have undertaken at the district level and at the field level to bring down the maternal mortality ratio as expected to 30 by 2020 and 20 by 2030. So the first thing is that we know that maternal anemia can predispose to postpartum hemorrhage, and hence addressing the adolescent anemia is an important factor. So for addressing the adolescent anemia, we have the WIFS program, that is a weekly iron folic acid supplementation program that is being implemented in the schools as well as in the Anganwadis. And this program gives elemental iron of 100 milligram and folic acid of 0.5 milligram. It is jointly organized by the Health Services Department and the Education Department. So the next important thing is, as we speak about the Kerala model of the health system, we are very proud about. And actually, we have a very robust primary healthcare system. We do have the PHCs and above which the CHCs, the taluk hospitals and the district hospitals. And at the grassroots level, it is the antenatal care that is being provided by the JPHNs and the ASHA workers. They are the grassroots level members actually. So the JPHN is entrusted with the whole of the maternal and the child health activities. She is the one who identifies, screens and identifies all the high risk pregnancies and gives appropriate reference to the nearest delivery points. And also the ASHA worker. So one ASHA worker is for 1,000 population and the JPHN is for a 5,000 population.
So that is the primary health component. Next, coming to the strengthening of the delivery points. As most of the speakers have mentioned, we have strengthened all our existing delivery points. In Kerala, we have total of 98 delivery points in the government sector. Tremendous improvement, lot of improvements in the infrastructure, especially in as Madam discussed about the ICU. We have the high dependency unit in some of the delivery points. We have high dependency unit. Most modern equipments we have purchased, and so that is about the infrastructure and the equipments as we have. And another important thing with regard to the delivery points is that we have envisaged to have a blood bank, either a blood bank or a blood storage unit in all of our delivery points. So these are some of the pictures of the excellent labor courts we are having. And another one is the labor suite actually, where we can have the companionship also in the delivery points. So next foremost, most important thing is the training and the capacity building. As Pailisa has rightly said, it has brought about a major change in in all the delivery points, because the KFOG have conducted elaborate training sessions involving the doctors, staff nurses from both government and the private sector. So that is a very, very important achievement we could have. So this is about the district level MMR training. As Madam has said, the participants from all the private hospitals as well as the government hospitals we could ensure. And it was actually a, practical sessions, hands-on training was given and workstations we had. So all the gynecologists were participating very enthusiastically, they were participating. So next is the quality assurance. In order to achieve quality standards in our healthcare settings, in all the healthcare institutions, we have constituted the state quality as well as the district quality assurance committees. And we have the district quality assurance team also. So all the private institutions, actually we are visiting all the private health institutions, we'll be identifying the gaps, and accreditation to the private hospitals will be given at the district level in the district quality assurance committee meeting, which is chaired by the district collector. So it is this, in this way, we are actually ensuring the standard of care in abortion services and medical termination of pregnancy services. So next is the implementation of the labor room protocols. We have in all the, as per the Lakshya standards, we have implemented the labor room protocols in all the delivery points. The use of partogram, that is very important in cutting down the cesarean sections, unwanted cesarean sections. We have the antibiotic policy. We have the SOPs for all the hypertensive disorders, PIH, PPH, etc. we have. And as Madam has mentioned, it is a right of every woman to have a dignified and a respectful labor. So it is a right of every woman to have a dignified and a respectful labor. For that, we have ensured the respectful maternity care. And another thing is the companionship. To allay the fear and anxiety of the labor pain, it is very important to have a companion during delivery. So we have ensured where we have labor suits, we have ensured that the husbands can be the companion, or in other places, a female companion. Female companion can be ensured. So another important thing, though we have the institutional deliveries, we have almost 100% institutional deliveries in Kerala, and only 30% are happening in the government sector, but most of the deliveries are in the private sector. But in government sector, the reducing the out-of-pocket expenditure of the mothers, that is very, very important. So we have the JSSK program, Janani Shishu Suraksha Karyakram, whereby all the diagnostic services, including the ultrasound and the treatment facilities for the mother and the newborn up to age 1 year, it will be completely free. We have the free referral transport mechanism. That is, whenever the patient is being referred from a delivery point to a tertiary care center, we have the referral transport with ambulances, BLS or ALS ambulances will be having. And another novel project we are having is the Madhuriyanam, whereby we are transporting the mothers as well as the babies. After delivery, they will be freely transported to their homes. The whole funding is being done by the NHM. So as mentioned, suicide being a very important determinant for this antenatal maternal deaths, we have implemented the Amma Manasu program along with the district mental health program. Then the maternal death and the near miss audit, which we have started in 2018. And we monthly, it is the responsibility of the RCH officer to convene the meetings every month with all the gynecologists from the private sector as well as the government sector and the government medical colleges. So it is being chaired by the district collector. It is a photo from Kollam where the district collector is very actively participating, and he was throughout in all the deliberations he participated. After 1 or 2, if he has time, definitely the collector will be joining our meeting. Otherwise, we'll be organizing with the district medical officer. Then the maternal death audit. It is actually maternal death audit we undertake. The RCH officer and a team of senior gynecologists and consultants from the medical college will be conducting a facility-based audit to find out the exact cause of death for the in this case. And we'll be submitting the reports to the additional DHS as well as a copy to the KFO. And the KFO will be conducting confidential medical review also on confidential death audit to confirm the cases of maternal death. And another important thing I wanted to stress is the reduction in sepsis we could bring about in all our healthcare institutions. Most important thing was the use of disposable delivery kits and disposable cesarean kits, which we have procured in all the 100% in the government institutions, and most of the private institutions are also following the same principle. So that has substantially reduced the chance of infections. And another important thing is we conducted training to nursing assistants and the hospital attenders, especially in autoclaving, disinfection measures, etc., which also contributed to a reduction in hospital-acquired infections. So these data have been already talked about by Pailisa, so I didn't go into the details. So these are some of the activities, because time is running short, so I very briefly explained about some of the activities we are conducting at the district level. Thank you. Thank you, sir.
Thank you, Krishnaveni. Next, we move on to the next session, that is IMR reduction, field success story to bring in connect with the policy with the interventions, for which I happily invite Dr. Sarita Madam, who is the pillar behind our entire health services system, and Dr. Srihari, who is the backbone of our favorite Hirdiyam program. Both of please come and give your words. Thank you.
A very good evening to all listeners. The way we had planned the session is that in the first few minutes, I'll be taking you through some glimpses from behind the scenes in Kerala IMR reduction. And after that, my young colleague, Dr. Srihari, will be talking on how we equipped our programs and institutions and topped up our efforts with the newer technologies. Well, we have already heard from Dr. Sachidananda Kamath about the policies adopted by the state to achieve the SDG goals regarding the infant mortality rate. Somewhere over the rainbow, skies are blue, and the dreams that you dare to dream really do come true. American poet E.H. Harburg wrote, but if you want the 7-colored rainbow, you have to deal with the rain. So here is the adventurous journey of the small state in India through the seasons to make the digit 7 visible through the implementation of the child health programs beyond the boundaries with its own innovations. It's because of the high level of political and administrative commitment, best intersectoral coordination and strong community participation, we could reach where we are now. Needless to mention about the role of the professional organizations, the Indian Medical Association, Indian Academy of Pediatrics, and Kerala Federation of Obstetricians and Gynecologists. Social factors like female literacy, standard of living, etc. were tackled by the concerned departments and organizations as and when the gap existed. Regarding the activities at the grassroots level, the health sector, our multipurpose workers and ASHA workers played the crucial role. They provided uninterrupted services to the pregnant women and babies in the field, ranging from health education, nutrition, preventive and promotive services. Kerala is the first state, baby-friendly hospital initiative state, which was declared in the year 2002 globally. But still our field team continued to support mothers on breastfeeding techniques so that no baby will be deprived of nutrition in the first few months of its life. Kerala is the state with high female literacy, women employment and empowerment, and consequently with perfect mobility of lactating mothers. And the health system have set the model for breastfeeding rooms in the family health centers, in the hospitals, and public places, which was later taken forward by various organizations. The state-of-art facility, Human Milk Bank, started functioning at Ernakulam by Rotary International with the support of Indian Medical Association and Indian Academy of Pediatrics. Regarding nutrition rehabilitation centers were established in the tribal areas for the institutional management of severe acute malnutrition. We never let our parents to shed tears when they lose their baby deprived of even tears due to dehydration. ORT, the mantra of acute diarrheal disease management is taught to each and every family here. And we continue to educate them through our ORT corners in the health facilities and depots in the field. Hence, dehydration death is non-existing in Kerala. Death of the infants due to vaccine preventable diseases is unknown to the health system of Kerala for the past few years. Kudos to the field team for educating, motivating, and creating attractive immunization facilities in the family health centers. The adolescents in Kerala, they know why they need to take rubella vaccination to prevent the birth defects. Thus, we could launch the measles rubella campaign with high coverage rates. We have started the free of cost rubella vaccination with the support of the Social Security Mission much prior to the global launch. Mental health of the mother is crucial to prevent the death of her baby. So we have conceptualized state-level mental health programs for antenatals, Amma Manasse, and Ashwa's clinics in the primary healthcare settings. The concept of Hamlet Asha, where we deployed Asha workers from the tribal community. It was a milestone in the infant health promotion in the tribal areas. Tribal health facilities are literally Arogya Kendras, as the team supported successfully the mothers by providing antenatal homes, nutrition, apart from safe delivery and newborn services. Kangaroo mother care, it's well known for nurturing preterm babies, but here, fathers too take the responsibility of kangaroo baby care, indicating the gender equality in the state. God's own country welcomes the guest, also treats them homely. Needless to mention that we conduct special medical camps for the guest workers and educate them in their language as far as possible, so that their infants can also avail all the healthcare services that a child in our own state get. Yes, the timer now reminds me that I should stop the talk now. Time can only stop us talking, but no one, including the COVID-19 pandemic, which brought the world standstill for some time, can stop Kerala working for their sustainable development goals. Though the virus could take away the colors of some families in the form of infants. Unfortunately, 3 were from our state. Thank you. Now invite Dr. Srihari for the continuation of the speech.
Thank you, madam. After wonderful narration of the field level activities in the state of Kerala, I'll be taking a few minutes to describe the activities that we carry out in institutions to reduce the neonatal and infant mortality. So even though the journey has started long back and the Kerala success story on infant mortality reduction is well appreciated, there were murmuring in the last decade when it looked stagnated, as Dr. Kamath pointed out. If you look at the graph shown, yes, it was true until 2015. When India has significantly reduced the IMR in the last 2 decades, Kerala has also recorded a reduction of 50%, bringing it down from 14 in 2000 to 7 in 2019. How is this made possible? When the Kerala infant mortality pattern was examined in detail with the support of Indian Academy of Pediatrics Kerala in 2013, it was observed that prematurity along with birth asphyxia followed by congenital anomalies, especially congenital heart disease, were the major 2 causes. Then based on the recommendations made by the state constituted infant mortality reduction working group, chaired by the additional chief secretary and later on by the principal secretary health, various steps were initiated. Few among them are detailed here. It is very much important to identify the actual causes, why infants die. So by strengthening the process of reporting, reviewing, and audit on infant mortality for proper planning and implementation. For this, district teams were constituted and trained using a pre-designed tool, including protocols for ascertaining the cause of death. It is expected that after analyzing the data, causes of avoidable mortality are listed for actionable points. And of course, community involvement through ASHA and other link workers encouraged for reporting all deaths. Monthly desk review is done at districts by the trained team of clinicians along with the administrators. They sit together, they discuss. The district line list is prepared with causes and recommendations, and this is forwarded to the state level group. The district reports are periodically discussed at the state level meetings to constitute policies and adopt revised strategies to support field level implementation. This is the comparison of 2018-19 and 19-20 information from the death review that happened across the state. So you can see that there is a sustainability and improvement in the process, which is evident from the numbers. In 2018-19, around 2,227 deaths were reviewed, and in 2019-20, 2,271 deaths were reviewed. The next 4 slides, I'll be talking a little bit on the pattern that we are seeing even now. The next 2 slides, this one and the next slide, it compares the neonatal mortality. From the numbers, you can see that the birth asphyxia, prematurity, and congenital malformations are still the major causes of neonatal mortality in the state. When you look at the postnatal mortality, again, congenital malformation and infections are the 2 major causes, which we are trying hard to decrease the numbers through our activities. So one of the most important strategy was to strengthen facility-based newborn care by establishing special newborn care units in all districts. And the measures taken up in the community level were already mentioned in the last presentation. Improvements in the facility-based newborn care includes providing new infrastructure for adding more beds. Ratio of bed to care providers improved significantly over the last, say, 5-6 years. Then trained human resources through capacity building programs, more and high-end equipment based on the service provision available in the units. This includes addition of bubble CPAP to all the units. Ventilators were provided to almost all the major units in the state, and even high-frequency ventilators were provided to major units across Kerala. All this resulted in improved access to care. The numbers you can see from 2018 to 2009, the admission in the public health facilities have improved. And the survival, definitely the early preterm and the very preterm survival has improved in the state. By improving the survival of preterm and the other babies, the total survival in the state is also found to be improving. But when you look at the numbers, the reduction in numbers may not be that big, but it is very significant, even when we are considering the very, very low neonatal and infant mortality in the state. It is noted that among the congenital malformation resulting in mortality, almost 50% of the mortality were due to congenital heart disease, and the state has taken up a special initiative called Hridyam for Little Hearts, which has already been discussed by many other speakers, where a patient care continuum of early identification, timely management, and follow-up is ensured through a web-based registry and cashless treatment offered in empaneled hospitals. Looking at the Kerala situational analysis, there is a 50% reduction, which is shown compared to the 2016 statistics. with regard to the mortality due to congenital heart disease in the state. But even now, there are more than 300 deaths per annum. It is estimated that almost 85% of all the critical congenital heart disease could avail treatment in the state for the last couple of years after the introduction of Rhythm program. A patient care continuum, as mentioned earlier, is established starting from case recognition, diagnosis and prioritization, a referral of cases, stabilization and transport, then the appropriate management at the appropriate level, then which includes a follow-up program, which is the specialty of this program. Special importance is being given to antenatal diagnosis through fetal heart screening using antenatal ultrasound and universal pulse oximetry of all newborn before discharge for recognition of congenital heart diseases. A special strategy is developed for community follow-up of cases to ensure timely management and picking up of early signs of any complications and implemented through health system. Considering the importance of quality of survival beyond initial survival, a comprehensive newborn screening program is rolled out in the state and findings are documented digitally in a web portal. This gives a web-based birth defect registry which helps in providing community-based follow-up. So this is the Shalavam Comprehensive Newborn Screening Program, which started in 2012 with the metabolic screening program in the state, which has different components. Visible birth defect screening done in the first 24 hours of birth of a baby, which is started in 2016 as part of the national flagship program RBSK. The hearing screening program, which is started in 2014 with the support of Kerala Social Security Mission, and that is offered to every newborn delivered in public sector and now with the support of Indian Academy of Pediatrics in all private institutions in Kerala, which is done post 48 hours before discharge of any child. Pulse oximetry screening is offered to all the newborn in public sector facilities for identification of congenital heart diseases, which is done 24 to 48 hours post-delivery. And the retinopathy prematurity is also one of the screening that we have initiated in all the tertiary care hospitals in the special newborn care units from 2018. Then the documentation of newborn screening is done digitally, and the data flow ensures that all the data for a particular child reaches the portal to a same point, and the whole data will be available against a child, which enables the system to follow up the child in the community. So when the child is screened for visible birth defects using the Android application, the data will be coming to the web portal, while the pulse oximetry is done at 24 to 48 hours. That data again will be coming to the same portal against the child's unique ID. And even though the OI screening is done by some other nurse supported by the Social Security Mission, the delivery point, that data is also flowing to the same portal. And the metabolic screening sample, which is taken in the delivery point and carried to the regional public health labs, and the test results are entered by the public health labs into the same portal, so that all information available against a single child against a unique number. So this enables the system to follow all these children, to follow up these children, and the follow-up is done through the district early intervention centers and the tertiary care institutions under the pediatrics department. This is the data that is for the newborn screening program, the comprehensive newborn screening against 4 different parameters. We are ensuring that all the newborn delivered in the state public health institutions are screened for all these 4 parameters, that we can see the 100% screening for all, 100% screening for visible birth defects is happening. Pulse oximetry that is significantly improving over years. The hearing screening, which is low in the beginning, now that is improving, and the metabolic screening also, that you can see from 72% that is improved to 92%. So ensuring a continuum of care under the principle of life cycle approach, every child will be screened and followed up until they're 18 years, and those detected with some birth defects will be supported through district early intervention centers and other programs for treatment and rehabilitation. Thank you.
Thank you, Dr. Srihari. So now it's time to wrap up the session. A big thanks to all the speakers, panelists, and special thanks to our Principal Secretary Health, Dr. Rajan Gobrede, and the State Mission Director, and Dr. Sriram Venkataraman IAS, our Joint Secretary Health. And a special thanks to all the listeners who continued to be online in spite of all the technical difficulty we had and made the webinar a big success today. So thank you and good night.
There is a Murphy's law. Murphy's law says if things have to go wrong, it will go wrong. So I profusely apologize all the listeners, audience who were there at the earlier session, but because of the technical reason, they could not join. We also apologize to our speakers. We have to all of a sudden ask them that your time is changed and now you will be speaking in the last session. So this disturbs all the speakers. We do understand, but for the technical reason, we have to do those adjustments and hope everybody will understand. But there is one more law, which is a law of averages. And law of averages tells us if one thing has gone wrong at the preliminary things, then at a final thing, everything will sail through very nicely. So next sessions, we will work hard to see that there are no technical glitches. Thank you very much and good night.